Okay. Let's start. Again, let's have adrenergic antagonist. So what are the objectives for this chapter? First, we will discuss the mechanism of actions of our adrenergic antagonist. And then we will be enumerating some important adrenergic antagonists and their clinical applications. We will have a bit of their toxicity, but let's concentrate more on their clinical applications and their mechanism of actions. Okay? So, what do you think are adrenergic antagonists? We are done with the agonist, right? But when you say agonist, these are drugs that have the ability to bind to the receptors and at the same time stimulate or activate those receptors. Agonist to siya. So we are done with that. Katong mga gipang answer nato sa quiz, those are the agonist. Those are the drugs that will activate the 5 receptors that we have for norepinephrine. So this time, let's talk about the antagonist. Si antagonist class, the important property of this is meron silang ability to bind to the receptors, but they don't activate it. So that's the difference between the two. Now, other name for adrenergic antagonist is, we can call it adrenergic blockers because they will just bind to the receptor, leading to the blockade of the binding of the original substance sa kanyang receptor. So hindi na makabind yung original substance, which is either norepinephrine or epinephrine, to the receptors. That is why blockers ang tawag. Or we can either call them as sympatholytics. Katong agonist, sympathomimetic because they mimic the action of norepi and epi. This time it's sympatholytics. Now, when you say adrenergic antagonist, these are drugs that will block the action of epi and norepi sa mga receptors. So from alpha 1, alpha 2, beta 1, beta 2, and beta 3. So let's move on. Let's have basic pharmacology of the alpha receptor antagonist drugs. Let's concentrate first sa mga alpha receptor antagonist, or we simply call them as alpha blockers. So mas common kasi silang tinatawag na alpha blockers kaysa sa alpha receptor antagonist. So what will be their mechanism of action? So these drugs plus they will bind either reversibly or irreversibly sa alpha receptor. So pwedeng ma-reverse, pwede siyang ma-reverse through kanang variation in concentration. So if we want to reverse the action of the blockers, we will just increase the dose of the agonist. But if the antagonist is irreversible, then even if you increase the dose or the concentration of your agonist, wala ka nang magagawa. Die forever sa ilahang binding with the alpha receptors. So when they bind to those receptors, the binding of norepi and epi will be blocked and it will be prevented. Okay? So let's start with the first drug. So please bear kasi these are actually students, these drugs are not also common sa inyo ha. But later, mahimo na siya common ng mga next nato na mga slides. But this time, phenoxybenzamine is not really that common, especially in the Philippines. Now, si phenoxybenzamine is not actually selective. So, bakit hindi siya selective? Kasi, it can either bind sa alpha 1 and alpha 2. So, pwede, both alpha receptors, pwedeng mag-bind si phenoxybenzamine. And the binding is irreversible and it can even take 14 to 48 hours or longer para sa pag-bind niya or pag-block niya sa phenoxybenzamine. So, why is this irreversible? Because the binding is covalent. So, that is a strong bond formed between most likely non-metals and non-metals. So, dili dyan mo siya ma-reverse. Now, para asa si phenoxybenzamine, this is the major treatment or one of the major treatment for pheochromocytosis. Cytoma. So yesterday, this is the reason why, di ba, nag-iwan ako ng activity kay Ma'am Charm about different conditions. So this is the reason why pina-research ko sa inyo yesterday. So based on your research, what is pheochromocytoma? Again, based on what you have researched, what is pheochromocytoma? Tumor sa adrenal glands. How about the others? Manawag ko or pag wala mag-volunteer, manawag ko? Or mag-answer na lang mo sa chat? Sa chat na lang. Kaya murag dili man mo mag-open sa inyong mga naka-mute man mo. This is mostly gatubo sa kidney tumor. Tumor that develops in an adrenal gland. Benign tumor in the adrenal glands. Okay? Sige. So actually, your answers are correct. Pheochromocytoma is a condition wherein there is a benign tumor. So benign is not cancerous ha. So benign tumor na mag-develop in the adrenal medulla. The question, where is adrenal medulla located in our body? Sa mana? Makita. Sa kidney? What else? What? You have other answers? Kumbaga mo, sige, top of the kidney. So may kidney banda sa taas. Sige. So that is correct. Mga na siya, nindot na siya mag-research kay based on experience from all the other batches I have handled. Pag mangutanan ako, where can we find adrenal medulla in the body? Ang answer dyan na nila kay brain. Nasaag na ang adrenal medulla sa brain. Ano sa brain plus it's medulla oblongata, it's not the adrenal medulla. So that is correct. Na ang adrenal nato gland is located right above the kidneys. So sa condition of pheochromocytoma, there will be a tumor that will be developed sa part na and that tumor class ang iyahang effect is magsige siya og release og norepinephrine and epinephrine. So again, the tumor will release epi and norepi. So if you have a lot of norepinephrine in the body, then daghan ang available for binding, especially to alpha-1 or alpha-1 receptor jud ang pinaka mag-bind siya. Now again, where can we find alpha-1? Major location of our alpha-1 receptor? Okay. Blood vessel. So that is blood vessel. Now what will be the effect if you stimulate the alpha-1 receptors in the blood vessel? What's the effect if you stimulate that? Vasoconstriction. So there will be vasoconstriction leading to increase in the blood pressure. Therefore, a person with pheochromocytoma will have increase in the blood pressure because of the binding of the norepinephrine na released from the tumor to the alpha-1 receptor. So since phenoxybenzamine is a blocker, we can give this to a person with pheochromocytoma. So paghatag nato plus, this will bind to alpha-1 receptor, though this is not selective, but anyway, since makabind siya sa alpha-1 receptor, then it's good. It can block the action of norepinephrine. There will no be vasoconstriction. Therefore, walang increase in the blood pressure. Okay? I hope nakuha to. Questions about phenoxybenzamine? Questions? Wala. Clarifications? Wala. Sige. Pag wala mo tubag, I assume na sabtan ha. Next, now how about the adverse effect of this drug? So, di ba, atong principle sa pharmacology, tanan drugs, whether it is synthetic or natural from the herbs, na na siya adverse effect. So, for phenoxybenzamine, okay, there will be orthostatic hypotension. When you say orthostatic hypotension, di pa research ako ni sa inyo ha. What do you mean by orthostatic hypotension? Sige, noted na ang mga wala dyo internet. Sige ka mo na sad para dili ako kighatag aning ang mga sakit dinhi. Sudden drop of the BP, sudden change in BP kada mag-change of position, yeah. Sudden drop of blood pressure. Okay, when you say orthostatic hypotension, there is, yeah, that is correct. There is sudden drop of the blood pressure, especially when you are changing position. So what change of position is that? It will be like from lying down or sitting to standing up. Kalit og drop ang blood pressure. Then what will happen to the patient? Actually, ang uban sa ilaha malipong jud. So there will be fainting. Ang uban sa ilaha kasi mo drop kalit ang ilahang blood pressure. So this is actually postural na condition. So depende siya sa posture. They will have like increase in blood pressure when they lie down, and then they will have a sudden drop in the blood pressure when they stand up. So actually, that is normal. When we stand up, there is really a sudden drop sa blood pressure. But our body can actually compensate it. So dili kay ta malipong. There will be times nga labi na kanang kalitan gud ta og like nag-squat ka and then suddenly nitindog ka. There will be times na feeling na to lipong, no? Pero we can actually adjust.
Ma'am, yung
yes,
bagong gising, ma'am.
Ansa? Bagong gising?
Yung sa pagbagong gising, ma'am.
Yeah.
Yes, ma'am.
Oh, from lying down.
Diba minsan, ma'am, pagbagong gising ka mahilo?
Yeah, when you change your position like from lying down, mukalit ka og tindog, yeah, pwede na siya mahitabo. Nag-drop dyan na ito ang BP class kasi when we stand up, supposedly, flow ang atoang blood padulong sa atoang tiil. Syempre kanitindog man ta. So there will be really decrease in decrease in the blood pressure. Saan ka nang may taho sa gawas? Ansa? Sakit sa ulo, yeah. But for this, sa phenoxybenzamine, ani ni siyang mahitabo sa phenoxybenzamine? Nganong na orthostatic hypotension, remember, i-inhibit niya ang vasoconstriction. So, there will be vasodilation, and since nag-dilate na atong mga blood vessels because of the drug, when the person stands up, diretso na gud ang blood padulong sa tiil, wala na yung resistance from the blood vessel kay nag-dilate na siya. So there will be a flow of the blood from the upper part of our body going down. That is why may pagbagsak sa blood pressure. Pag wala kasi ta nag-inom og drug like this one, actually our body will also adjust. Pag from lying down, pag mutindog ta, our body will actually constrict the blood vessel para walay sudden drop of the blood pressure. Constrict ng blood vessel para ang flow sa blood from the upper part of our body to the lower part can be controlled. Okay, so di na siya makontrol if we take this kind of drug. Next, we have nasal stuffiness. Kasi remember, there will be dilation for this. And when you take this drug, it's not just for the blood vessels sa mga other parts sa atong body. It's included lahat ng parts sa body natin. And then, included ang mga airways natin sa mga blood vessels dyan. So there will be dilation. So the patient may experience nasal stuffiness. Okay? So, sa mga adverse effects sa drugs is actually effect lang po na nila. Kaya lang some other parts of the body na. And then inhibits male ejaculation. So nga naman babae tanan no. So walay makarelate kay babae tanan. Sa para sa mga lalaki class, alpha 1 receptors are concentrated siya. Daghan siya sa part sa ilahang reproductive system, sa ilahang prostate gland. And alpha 1 receptors, pag mabind ang norepinephrine din mag-cause siya og excitation for them, included din ang pag-ejaculate. However, since this drug will inhibit the binding of norepinephrine sa alpha 1 receptor, then included po ang pag-inhibit sa ilahang ejaculation. So, maulang na siya ang problem with this type of drug. Questions so far? May question there. Wait. Actually, you will seek attention sa doctor if pirmi na siya mahitabo sa imuha na when you change your position, mag-drop jud imuhang BP and then mag-lead jud siya into fainting. Kapag pirmi-pirmi na siya, that's the time you really have to seek attention from the physician. However, it is normal for us to experience that from time to time. But if you are healthy, actually your body can adjust easily. When we have our chapter for the hypertension, I will explain to you what happened to our body during regulation of the blood pressure. Okay? So again, pheochromocytoma is a tumor of the adrenal medulla or sympathetic ganglion cells. And this tumor will secrete norepi and epinephrine, leading to the increase in the blood pressure. Now, another drug which is also a non-selective alpha blocker, meaning it can either bind to alpha 1 receptor or to the alpha 1 receptor, is the phentolamine. But this time, ang kaibahan nila sa phenoxybenzamine, this one is a competitive antagonist. Now, when you say competitive antagonist, it will compete with norepi and epinephrine in the binding site, but it can be reversed. So mao ni siya ang alpha blocker na reversible. You just have to increase the concentration of either the epinephrine or the norepinephrine to reverse the action of phentolamine. But however, they have the same clinical application that's still pheochromocytoma. But we have additional adverse effect here. We have the severe tachycardia or arrhythmia. This is actually brought by the sudden decrease in the blood pressure. If we have decrease in the blood pressure, our body will look for ways na ma-compensate. So one mechanism to compensate the decrease in the blood pressure is to increase the heart rate. So that is why the patient may experience increase in heart rate, or we have here severe tachycardia or arrhythmia. There will be irregular heartbeat. And myocardial ischemia. So there will be blockade of the flow of the blood sa mga blood vessels nato, especially sa heart. So makulang na siya og oxygen. So that is phentolamine. So we only have two drugs that are not selective for alpha blockers. You can ask questions anytime, ha? Now let's move on to the selective. Kani class, selective na siya but for alpha 1 receptor. Selective alpha-1 antagonist. So their mechanism of action, basically they will bind to alpha-1 receptors, block the action of norepi and epi, and even all other catecholamines. So wala na, dili na makatake og action si norepi and si epi. So dali lang ni sila maalala, class, ang atong mga selective alpha-1 blockers, most of them end with zosine. So we have here, like example, the prazosin, which is an effective drug for the management of hypertension. So remember, do not ever forget asa located si alpha-1 receptor, class, sa blood vessel. And if we inhibit the action of norepi sa blood vessel, then there will be vasodilation leading to the decrease in the blood pressure. That is why prazosin is given for patients with hypertension. So do not forget, ha, it's a selective alpha-1 receptor antagonist. Choppy, basin hinay ang internet. Choppy ba ko sa uban or kay Tin lang? Basig akong internet ang hinay. Wala. So kay Tin lang. Sige. So when you take prazosin, class, since it will inhibit the action of norepi and epi in the blood vessel, it will lead to relaxation of both arteries and veins. So di ba, remember we have blood vessels. When we talk about blood vessels, we have two types, like the arteries and the veins. For prazosin, it's both. Kaya naman good tayo mga anti-hypertensive drugs, class, na specific for the arteries, and napod tayo specific for the veins. But before that, bidaw, naminaw ni sa ilahang anatomy and physiology, what's the difference between arteries and veins? Magulat jud ta, dili kita mag-move on. Wala. Breathe. Ambot. Sundog-sundog na si Rosel sa akong brain error ba? Arteries carry oxygen-rich blood. Arteries oxygenated. Credits na siya sa research Gabilagon 2021. Si arteries, ma'am, nag-carry oxygen, tapos si vein palabas. Ano siya, class? Ang inyong tandaan, si arteries, they carry blood from the heart. So definitely, it's oxygenated from the heart going to the body. So gikan na siya sa gikan na po siya sa lungs, no? That is why nanay oxygen. Now, if na-use na ang oxygen sa blood, then it will go back to the heart and it will flow via the veins. So the veins carry the oxygenated blood. So it's from the body na going back to the heart. I hope you will not forget that. Dili ta mag-brain error pag abot sa ingana ng mga butang. Okay? Next, we also have terazosin. These drugs have the same mechanism of action. Ang kalahian lang nila, class, syempre their structure, at the same time their pharmacokinetic profile. So when I say pharmacokinetic profile, ang ilahang duration of action, ang ilahang time na mag-peak sa blood, ano ang difference nila. But they have the same mechanism of action. So this is another reversible alpha-1 selective antagonist na ginagamit gihapon for hypertension. And at the same time, let's add another use of the zosins. We have the BPH, or the benign prostatic hyperplasia. So this is included sa akong gipa-research. So maningil ko. So how do you describe this condition, the benign prostatic hyperplasia? Kasi na may madunggan ha. Si Ma'am Cherry na adri sa akong likod. I don't know if madunggan ninyo siya. Wala po sila internet sa ilang balay, kay PLDT sila. So nangapit bahay siya, na siya diri sa mga karon. Kasi lang madunggan ninyo sila. Madunggan mo siya di ay. Kaya sa prostate enlargement, yeah, mostly sa mga lalaki dyan na siya, kay sila lang ang naay prostate. Wala tayo prostate, no? Enlarged prostate gland, labi na pagmanigwang. Yeah. There are men na as they age, their prostate continually increase. So when you say hyperplasia, there is increase in the cells, the number of cells in an organ. So kung nag-increase ang cell, most likely mag-increase ang size sa organ. Now, prostate is located beneath the urinary bladder sa mga lalaki. Now, pag magdako na ang ilahang prostate, syempre there will be effect in the urinary bladder. So, naa sila yung mga urinary symptoms. Okay? When you say BPH, it's not actually cancerous, but it can lead to having prostate cancer. Pwede. Pwede siya madiretso dito. But, dira siya mag-start sa BPH, benign prostatic hyperplasia. Pati nga lang, sabi ko na ay prostate. So, wala yung babae nga nag-BPH, kaya wala tayo prostate. So, sa mga lalaki na siya, class. Now, again, they have urinary symptoms. Usahay, they have urinary incontinence. Not usahay. Mostly, they have urinary incontinence. Pag moingon sila kaihion, manghihi na sila diretso. Kasi remember, maipit magod ang ilahang urinary bladder because of the increase in the size of their prostate. So, kana mga urinary symptoms. Now, why is the zosins used for this kind of condition? Alpha-1 receptors can also be found in the prostate sa mga lalaki. And ang effect man good ni alpha-1 nga stimulation is most likely contraction. But since we are blocking it, mag-cause man good siya relaxation. So pag mag-relax na ang mga smooth muscles din ha, including the urinary bladder, then we can treat urinary symptoms of males na may benign prostatic hyperplasia. What do you mean trans, Tin? What do you mean by that? Yeah, if their prostates were not removed, then they can have this. Okay? They can have this if wala gi-remove. Wala ba na gina-remove ilahang prostate? I don't know. With the trans. Okay, another one is the doxazocin. This can also be used for hypertension at the same time for BPH. But what is the advantage of doxazocin compared to prazosin and terazocin? This drug has longer half-life. So it will stay longer in the body, causing sa pag-increase sa duration of action and then leading to like once a day dosage regimen. So kung longer ang half-life sa atuang drug, so mag-lesser pod ang regimen. So pwede na siya once a day. So lisod man good, especially for our elderly, if hatagan nato sila og short-acting na mga drugs, then they have to take the drug for how many times a day, and most of them makalimot-limot na, so they might skip their dose kung makalimot sila. And next, this one is an alpha-1 blocker that does not end with zocin, but definitely it's an alpha-1 blocker. We have the tamsulosin. Actually, natay brand sa market. I hope you can have your internship. Mahumanawon ta ni ato ang situation so that you can be familiar with these drugs. So nata sa market, dili lang ko kalimot because this is very saleable sa market. Tamsulosin plus finasteride. This is a combination drug. Their brand name is Dudart. Okay. Ano siya ang pinakaginagamit para sa mga male with benign prostatic hyperplasia. Okay? So this is again a competitive alpha-1 receptor antagonist with a structure quite different from the others. That is the reason why it has a different name. So dili siya pareho with the zosins. Na siya it's dutasteride. Sorry. It's dutasteride, not finasteride. Another drug ang finasteride. Pag Duodart, it's dutasteride. Asa na ta? Tamsulosin has a quite different structure from other drugs. That is why wala siya nag-end sa zosin. But anyway, it's also effective in relaxing the prostate smooth muscle. So pwede gid siya for BPH. Okay? So again, mo ni ang pinakasikat sa market, though we have other drugs. So si dutasteride and si finasteride, isa pod sila ka-family, but we will not yet discuss them because they are not really considered alpha-1 blockers. So they have different mechanism of action, though hinahatag pod siya sa mga prostate na condition. Okay? Questions so far, class? Yeah, Avodart. That is a single drug only to relax also the prostate smooth muscle. Your father has BPH, Isabel? Okay. So, ang dutasteride is just a single agent for relaxing the prostate smooth muscle. But if the condition is a bit severe, then that's the time we use the combination drug, the tamsulosin plus dutasteride. It's the Dudart. Pirmi na siya itong nag-work ako sa class sa Rose Pharmacy. Pirmi ni siya maubusan og stock. Daghan siguro ang case sa BPH kay pirmi man siya out of stock. Lang. Ipastop na siya sa doctor. Okay. There's actually I don't know if it has already been proven, but when you are exposed with tamsulosin, na siya effect na makabaog according to them. But I have not yet seen a study and at the same time an FDA na advisory na it can really cause mabaog ka. Muna siya, mga lalaki na mga pharmacist, dili sila, pharmacist or pharmacy aid, dili sila mo ganahan mo dispense ani kay ma-expose daw sila. I don't know ha. Wala na balak yung parents. Oh, okay. Kung wala na balak, that's okay. Para lang sa mga uban. Okay, do not forget that ha. Next, alfuzosin is another one, a quinazoline derivative that is also approved sa ihang gamit for BPH. So no need to, the mechanism of action, parehas lang sila tanan of mechanism of action. Not really. Not everyone can experience benign prostatic hyperplasia when they get old, but daghan ang case for benign prostatic hyperplasia sa ato. May connection siya sa erectile dysfunction. Actually, wala. The erectile dysfunction is a different thing. Okay? Though later, madiscuss nato si erectile dysfunction, gamay lang siya, pero, well, anyway, later ha. Nata diri kasi alpha receptor can also be found sa kanang part sa lalaki sa ilahang reproductive organ, and ang isa ka effect is the erection. Okay? Pag mag-undergo sila og surgery, what kind of surgery, Jai? Surgery for what? Protas pro prostatectomy? Prostate? Yeah, pag wala na sila, prostate is a very important organ for them. Dira na-release, dira ginahimo, gina-produce ang ilahang seminal fluid. So without the prostate, asa sila magkuha sa ilahang seminal fluid? Okay? Ang BPH, magkaroon ng problem with the urination, mostly mga urinary symptoms, but the problem if mauwi siya into cancer. Okay, anything else? Wala? Now, adverse effect of our alpha-1 antagonist. So, tanan drugs na ay adverse effect. Ang pinakatandaan dyan ninyo, the first dose syncope or phenomenon. That's really, connected to alpha-1 receptor. Maginiiyahang adverse effect. First dose syncope or phenomenon. What do you mean by this? If you give this to patients, there will be a sudden drop sa ilahang BP to the point that there will be fainting, there will be dizziness. Mukalit og drop ang ilahang BP after taking the alpha-1 antagonist. So as future pharmacist pohon, you really have to take note of this and you have to remember this by heart kasi you have to counsel the patient, and not just the patient. You can also give information to physician, though I know na kabaluman sila ani, but there will be times that we have to remind them about the effect of the alpha-1 antagonist. So what will be our stand for this? For alpha-1 antagonist, you have to remind the physician na during the first dose, number 1, the physician should taper the dose, meaning mag-start siya sa pinakagamay nga dose. So, pwede gani nga hation. Most of these drugs are scored, meaning na sila'y hati sa gitna. Pag ang tablet plus may hati sa gitna, that's the time we can break the tablet into half. But if you cannot see a score dito sa tablet, dili gani mo na siya tungaon ha. Kay dili siya pwede. Dili uniformly distributed ang iyahang ang iyahang active ingredient. So for this one, pwede siya tungaon sa on the first dose para maka-adjust ang body sa pag-drop sa iyahang blood pressure. And then another one, number 2, this should be given at bedtime. Kay para padulungay na siya matulog, dili na siya maka-experience of dizziness and fainting. Unsa ang dili uso sa Philippines, Jessa? Unsa dili uso? Ang pag-score. Ihati dyan ang tablet. Dili dyan mo, you advise pag pharmacist na mo puhon, you have to advise, or you have to counsel the patient. If wala score, ayaw hati ha? Pag na-score, that's the time you can. Na-score ang music. Sa kadugay na nako class nga wala nakasulod og butika, I'm not really sure with the appearance of those drugs anymore. But I know them. If you tell me the generic name, I know them. But when it comes to appearance, I'm not confident anymore. Dugay na ko wala kasulod og butika. And pag pharmacist baya ka, the irony is di ka mo inom og tambal. So dugay na mi nagkita sa tambal class. Okay. Biogesic also. Okay. So you can break that into half. Okay, so let's talk about other alpha adrenoceptor antagonist. Oblong is called a couplet ha. Ibago man nilang appearance karon sa biogesic sa Newzep, no? So dili na siya round na tablet, we call it couplet. Ano siya capsule. Okay? Couplet. I'm not really sure why. Anong nag-change sila? O ka ng appearance. Appearance lang na, pero it's the same thing. The brand is still the same. The generic is the same. Parehas lang. Sa ano lang, sa appearance sa tablet. Okay. Again, let's move on to other alpha adrenoceptor antagonists. Okay. So the first one is indoramine. This is another alpha-1 receptor blocker used for hypertension, but not anymore available in the USA. At the same time, I don't know if this is available in the Philippines. Kasi from the time na nag-duty ko during internship when I was a student, that was more than 10 years ago. And then, hangtod sa nagtrabaho ko sa mga butika, ako kitag indoramine class. Okay? But anyway, this one is an alpha blocker for hypertension. And then we have urapidil, which is an alpha-1 antagonist. So this one is actually good because this is an alpha-1 antagonist, meaning it can be used to treat hypertension and at the same time, alpha-2 agonist siya. Another effect in the decrease of the blood pressure. And may weak antagonist action siya on the beta-1 receptor to slow down the heart. So that's urapidil. Now, you cannot also see this in the Philippines. This is available in Europe as an antihypertensive drug and for BPH. And then we have labetalol, which is actually a beta blocker. So later, pag mag-discuss to beta blocker, we will also discuss labetalol. Pero this is the reason why it does not end with olol. Diba? Kasi you have beta blockers and with olol. But this is an exception, the labetalol. And the A there indicates na meron siyang action on the alpha receptor. Aside from the blocking the beta-1 receptor, it can also block the alpha-1 receptor. So take note class of the exceptions kasi most likely mo na siya mga favorite things na i-ask. And then we have neuroleptic drugs. So these drugs is they are antipsychotic drugs. So para siya sa psychosis. But aside sa ilahang effect on the receptors involved in psychosis like the dopamine receptor, naapod sila action on the alpha receptor. So they are antagonists and their action on the alpha receptor will explain their adverse effects. Okay? So we have examples like chlorpromazine and haloperidol. Again, they are neuroleptic drugs. They can be given to patients with psychosis and other mental disorders. Okay? So, ang kanimang na sila nga drug, pag ihatag ni sila sa patient, the patient will experience hypotension. There will be sudden drop in their BP. And the one that will explain this is their action on the alpha receptor. Okay, dili niya gamit ha ang para sa pagbaba sa BP, instead adverse effect. And then we have trazodone, another drug that is not really used for hypertension pero naging adverse effect na niya ang hypotension, pagbaba sa BP. Trazodone plus is an antidepressant. So we'll have more of that, including the neuroleptics in the previous slide if we reach na the chapters for the central nervous system. And then we have the ergot derivatives. Ergot class is actually, wait, let me write sa screen, text na lang, or i-type ko na lang. Pag sinabing ergot derivatives or ergot alkaloids, they are derivatives not sa plant but sa fungus called Claviceps purpurea. Ay, wait. Hindi siya ma-italics. Anyway, Claviceps. I-italics na lang ninyo ha. Claviceps purpurea. So that's the name of the fungus, the Claviceps purpurea. Nag-release siya alkaloid and we call the alkaloids ergot alkaloids or ergot derivatives. Daghan mo sila. So we have examples like ergotamine and dihydroergotamine. na naay action on the alpha receptor blockade. Now, when are we going to discuss thoroughly the ergot derivatives? When we reach the autacoid pharmacology, kasi the effect of ergotamine is more on the serotonin than the alpha receptor. So this will just be its like adverse effect. Okay? Questions so far? Wala? Do you want to take a CR break? CR break ta 5 minutes. Sige, CR break sa tam. Sige, hiuna mo din hanya dili ko muundang no. Sige. So next we have the euhimbine. Now this one is an alkaloid, an indole alkaloid to be exact, but it's different from the alpha agonist that we have discussed. Kasi this one is selective sa alpha 2. So this one is an alpha 2 selective antagonist. So do not forget class, the major location of our alpha 2 agonist is still pre-synapse and on the blood vessels, smooth muscles gihapon, any smooth muscles. And actually, stimulation of the alpha 2 receptor will cause vasodilation for some blood vessels, and it can inhibit the release of norepinephrine. So most likely, pag stimulation ha, para siya sa may naay hypertension. But this time, since this is an antagonist, we can use this for people with orthostatic hypotension. So this is an opposite of the alpha 1 because orthostatic hypotension is an adverse effect of blocking the alpha 1. This time, it's the effect of blocking the alpha 2 receptor. So, kasi pag i-block mo si alpha-2 receptor, the release of norepinephrine will not be inhibited anymore. And then you will have more norepinephrine available for binding. So, pwede na magtaas ang imuhang blood pressure. And at the same time, alpha-2 receptors are actually found in the blood vessels of the male also, especially in their reproductive system. Now, euhimbine was actually once used for erectile dysfunction in male. Dati ha, ginagamit siya, but these days class, ang gamit ni euhimbine is already superseded by our PDE5 inhibitors or the phosphodiesterase 5 inhibitor. Example of that is sildenafil. Brand name of sildenafil in the market is Viagra. Are you familiar with Viagra? So again ha, dati ginagamit ni siya for erectile dysfunction sa male. Kasi this will cause vasodilation class. And for males, the more nga daghan ang blood flow sa kanilang sa kanilang what you call that reproductive system, the more nga mag-function siya fully. So pag may erectile dysfunction sila, this can be given. Now, ngayon, this one is not really that used anymore. But mas ginagamit na nato si Viagra. So iba po ang mechanism of action ni Viagra. It has nothing to do with the alpha receptor. Instead, dito siya sa PDE5. That's another enzyme. I will have a separate discussion of the Viagra sa lahi na chapter. Okay? Next, it can reverse the antihypertensive effects of alpha-2 adrenoceptor agonists such as clonidine. So si clonidine alpha-2 agonist, if we want to reverse the antihypertensive effect of clonidine, then we can use the euhimbine. Pero isa lang na siya kabuo class ang naga-inhibit sa alpha-2 receptor. We are done with the alpha receptor blockers. Questions? Before ta mag-proceed sa next, the beta blockers. Wala. Beta blockers na ta. Actually, you are more familiar sa beta blockers than the alpha blockers. Kasi mas common man yun ginagamit ang beta receptor antagonist nato. So, beta receptors. We're now talking about the beta receptors, ha. Let me, wait ha, let me, ay, sorry, nawala. Kajot. Sana lang mga oldies, Manila maintenance drug. Okay, so ako na siyang gi-exit. Kaya ako siyang i-edit. Okay? Let me edit that kasi propranolol lang ang nakabutang. It's propranolol. Class, among our beta blockers, this is the first drug, the prototype, the propranolol. So this one is a beta adrenergic antagonist, but it is not selective class. Propranolol is both beta 1 and 2 receptor antagonist and with an equal affinity to that. So it can bind either sa beta 1 or sa beta 2. Now, aside from the propranolol, this is true for all beta blockers. So katong mga nag-end sa olol. Okay? So the first one, what are the effects of beta blockers sa cardiovascular system? Remember that beta 1 receptor is most likely found in the heart. Stimulating the beta 1 receptor can lead to excitation sa function sa heart. But what will happen if we inhibit the beta 1 receptor through these drugs? So the first one, if given chronically or for a long period of time, our beta blockers can actually lower the blood pressure in patients with hypertension. Kasi when you slow down the heart, class, kasi blocker man, so slowing down, not stimulation. When you slow down the heart, it will also result to the decrease in the blood pressure. That is why our beta blockers have become maintenance drugs for this condition. And aside from that, from the effect on the blood pressure, syempre, ang effect niya sa heart. So we have a lot of conditions wherein we use the beta blocker. So example of those, we have the angina pectoris, where the patient experiences pain sa heart, chest pain, because of lack of oxygen in the heart mismo. Pag nag-angina ang patient class, there is lack of oxygen in the heart. Kasi the blood vessels or the myocardial na mga blood vessels are na yung mga obstruction. So it can be atherosclerosis, mga plaques, cholesterol plaques na na-develop sa blood vessels. So nag-cause of obstruction, hindi na maka-flow tarong ang blood and dili na siya masuplayan ng oxygen. Our heart also needs oxygen. And then we also have chronic heart failure. So this time, sa heart failure naman, syempre nag-fail ang heart sa iyang function, and that is to pump blood all throughout the body so that oxygen will be delivered. So ang person class with a heart failure, ingani po, there will be lack of oxygen but in the body. Other parts in the body because hinay ang pag-function sa heart. But pahinayon pag yun nato na siya using the beta blockers. So, pahinayon ma'am? Mingon ka, ma'am, hinay na gani. Nag-heart failure na gani siya. Pahinayon pa jud with the beta blockers. Kasi, class, if papaspaso na to ang heart sa person with a chronic heart failure, mas madali masira ang heart nila. So, that is why ato siyang i-protect from further damage. So, ato siyang i-inhibit ang iyahang pag-excite. And then we have myocardial infarction, or like we have heart attack, or sa layman's term, cardiac arrest. We can also give this to patients with this condition because of its negative inotropic and chronotropic effect. So especially if there is blockade in the blood vessels of the heart, we really have to slow down the heart para dili siya makapoy sigig trabaho. And kapag makapoy na siya, that will lead to further damage of the heart muscles. Okay? But we have another separate chapter for the heart failure alone. Daghan kay tag-i-discuss sa pharmacology. That is why PICOL 1 ug PICOL 2 dyan ni siya. Actually, kung naapay PICOL 3, mas nindot ng tato. Next, effects on the respiratory tract. This is true for those na non-selective ha. So where is the major location of our beta 2 receptors? Kung beta 1 is in the heart, beta 2 is in the bronchioles or sa lungs. So, kung mag-stimulate ka og beta 2 receptor, supposedly bronchodilation na siya. But if we block it, it will cause bronchoconstriction. Therefore, itong mga non-selective olols natin or mga beta blockers natin is not really good for patients with asthma. Kasi it will cause bronchoconstriction and mag-increase ang airway resistance. Next, effect on the eyes. Aside from beta receptors in the heart and in the bronchioles, beta receptors can also be found sa atong mata. And blocking the beta receptors in the eyes will lead to the decrease in the intraocular pressure because of the decrease in the production of the aqueous humor, that is our fluid sa mata. And that is the reason why we have beta blockers na instead of giving them to hypertensive people or those with heart conditions, we give the drug to glaucoma. So, di ba, the problem with glaucoma is there is increased intraocular pressure. So, we can give this para mag-decrease. Next, metabolic and endocrine effects. If we give beta blockers to our patient, syempre this will inhibit stimulation of the sympathetic nervous system, including the lipolysis. So, dili mag-breakdown ang mga fats if we give beta blockers. And at the same time, can mask the hypoglycemic signs and symptoms. So, ano ni siya? Pag pharmacist na mo pohon class, especially pag clinical pharmacist, no, you really have to take note of the different drug-to-drug interactions. So, most of the time, triad man gud ang ato ang sakit. If there is diabetes, there is increase in the blood pressure, mauwi sa sakit sa heart, sometimes sa kidneys. So, definitely, kani si beta blocker, since common siya, ginahatag po siya. Na paano kung diabetic ang patient? You really have to keep track of this. But as much as possible, dili na lang sabayon si beta blockers sa mga anti-diabetic drugs. As much as possible ha. But if we don't have any substitution, then yes, we can give them concomitantly, sabay, pero we need to monitor. Kasi when you give a person with beta blockers, you can no longer monitor if the patient is already experiencing hypoglycemia because of the drug niya sa diabetes. So, unsa day ng mga hypoglycemic signs? Pag mag-hypoglycemia manggod ka class, there will be increase in heart rate, you will have excessive na sweating, pag magkulang na ka og sugar, makulang na siya, for example, sa diabetic na patient, basig masubraan siya, especially pag metformin ang iyahang tambal, pwede siya mag-hypoglycemia ang patient. And pag gisabayan mo na siya beta blocker, mamask na niya ang hypoglycemic effect. Pareha sa tachycardia, unya, gihatagan nimo siya with the beta blockers that can decrease the heart rate. Now, you cannot see already na the patient is having hypoglycemia. So, mawala na siya ang reason why, as much as possible, dili na to isabay ang mga anti-diabetic drugs with our olols. Para lang makakip track ta. Kay mas delikado, di ba, ang hypoglycemia compared to hyperglycemia. So, daghan yung cases na pag masubraan ng patient with anti-diabetic drug, magkaroon og problem sa hypoglycemia. Okay, question so far, class? Wala? Sure na gyud. Mata pa mo, basig na sige kung istorya dirihan ya natog na day mo diha. Alive.
Nandito pa kami, ma'am.
Alive na, wala pa mo nag-on og cam. Feeling na ko ba naghigda-higda ni sila dire, nagligid-ligid. Feeling na ko ani sa ila walay ilis.
Ma'am?
Dili mag-on og cam. Feeling jud nako, ana jud ang mga estudyante. Nya ano dayon, pasangil dayon ma'am, wala ko'y cam ni. Pag sure mo. Alam na. Alam na good na. Ay, naka-uniform ka, Tin. Sana all naka-uniform. Warang estudyante naka-uniform. Ang laptop, walay cam. Okay. I have no problem with that. Dili ta mo mapugos kung di mo mag-on og cam. Uy, alam, pugson ta mo. Saan ta pagpugos? At tuwan ta mo sa inyong mga kanya-kanyang balay. Intermission number para mabuhi atong kalag. Okay. So let's move on. Therapeutic uses of our olols or the beta blockers. Maulaw mo? Ano maulaman mo? We have first the hypertension, syempre. Para siya sa hypertension because chronic use of our beta blockers will lead to the decrease in the blood pressure, especially if it can slow down the heart. And then, angina pectoris, that is chest pain due to like blockade in the flow of the blood sa heart muscles. So para mag-decrease ang kanang trabaho gani sa heart, magtrabaho gani manggod na siya og daghan basta kulang. So ato siyang i-slow down pero para to protect our heart from further damage. Included also si myocardial infarction. And nganong naa si migraine din ha. How would you differentiate migraine from kasi tawag ano ganing headache na sakit lang mong ulo, normal one, the normal headache. How do you differentiate that sa migraine? Anyone here? Ako, I have migraine. I have optical migraine. Mag-migraine ko basta stress ko. Especially if kulang kong tulog. How do you differentiate? What's the difference? Actually, most of the time when you have migraine, it's just unilateral. So it's one half of sa imuhang ulo ang sakit. Like kung ako, if I have migraine, ang sakit is from here going here only. Di siya pantay. Maglagot ko kay di siya pantay. Lamig siya bunggoon if sakit na. Pero don't do that. Don't do that. So, a right side imo, Isabel. Ako actually, it's the left side per me ang sakit pag naga-migraine ko. Especially if kulang po tulog. So, ang kalahian kasi sa migraine, mao na siya aura. Aura ang migraine. You will actually know nga padulungay na ka mag-migraine kasi naay mga signs na padulong na dito. Okay? So, nagavary ang signs. So, ang usahay, there is light. Nay something sa imuhang panan, blurry. Ang uban makakitag mga light na mga unsa-unsa. Or lain imuhang feeling, there is lightheadedness. Ang aura na siya sa migraine. So, wala siya ang mga palatandaan nga padulungay na ka mag-migraine. So, during that time, there is like vasoconstriction. Pag nag-aura ka sa migraine, nag-constrict ang mga blood vessels sa imuhang ulo. Tapos, after the vasoconstriction, there is rebound vasodilation. So, mukalit og dilate ang mga blood vessels. And then, once nag-dilate ang mga blood vessels, daghan siya mga mahitabo. Number 1, there will be stretching of the pain receptors. Kaya ni-dilate man ang imuhang blood vessels. So, taas ang blood flow sa imuhang ulo. So, that is painful. Okay? Pero pag normal headache lang, actually, it is just vasodilation. Wala siya constriction una, tapos mo dilate. Si normal na headache, what do you call that? na normally may experience nato na headache, ano lang siya diretso, vasodilation lang siya. Okay? So sakit ang migraine, 1/2 lang. There is nausea, others will experience vomiting. Nag-migraine sila. Lami kumuto ng buhok, no? O lami kumuto ng buhok pag nag-migraine. So mo na siya karon, parehas karon murag kulang kog tulog daghan kay kog himo o nagatambak akong trabaho na actually nagapanagang ko gusto jud ko matulog og sakto kay murag padulungay na mag-migraine kay ang akong aura jud kay magsugod gyud na siya sa akong mata. So karon murag ma-experience na ko siya. Ako siya gusto madayunan. So paano mawala ang migraine? You have to avoid things that will trigger the migraine ha. Number 1 gyud din ha ang stress, tulog pud og sakto. And then there are foods na need na to ilikayan when it comes to migraine, mga preservatives. Chocolate is another one. You have to avoid those foods. Okay? Kapag tayo separate na chapter for headache alone. So, daghan tag klaseng headache. Cluster headache, tension headache, then we have migraine. Yeah, MSG, Isobel. Let's avoid those things kay naatay migraine. And then hyperthyroidism class. By the way, pag sa severe nga migraine, sa ginatagaan ng mga beta blockers to constrict and to inhibit too much flow of blood sa ulo. Then we have hyperthyroidism. So we have like overactive thyroid glands, and then there is increase in the thyroid hormone that will lead to the increase in the heart rate. So mo jud ang problema with persons na may hyperthyroidism kasi they will have arrhythmia after. And because they have arrhythmia, that is why included sa therapeutic use sa mga olols ang hyperthyroidism. Now, adverse effects, syempre, if the beta blocker is not selective, pwede siya mag-bind sa beta-2 receptor causing bronchoconstriction, and that is why if it is not selective, we don't really give that to people with COPD and at the same time, asthma. And then, adverse effect arrhythmia, kasi pwede na to siya ihatag sa arrhythmia, but it can also cause arrhythmia, especially if you have normal heartbeat, tapos mo siyang ihatag, i-take me mo siya. So, ma-disrupt, ma-destroy ang homeostasis sa sulod, causing irregular heartbeat. And then, sexual impairment, magbaba ang libido, ani, and metabolic disturbances and CNS na mga effects. So let's talk, ang pinaka-importante din here, let's group our beta blockers. So you have to know kung kinsa ang selective for beta-1 receptors alone and kinsa ang mga non-selective. So example sa mga non-selective beta blockers or beta antagonist, included diri si propranolol class. So we have the nadolol and the timolol, which means dapat dili na daw siya ihatag pag ang patient na ay asthma or COPD. But class timolol as well as betaxolol and carcholol, mo ni ang mga beta blockers nato. Now we can give to patients with glaucoma. So para mag-decrease ang intraocular pressure. Take note ha, timolol, betaxolol, and carcholol. So dili kay nato sila makita tatlo for hypertension, but for glaucoma. And then, take note of this. Mauni ang mga selective beta-1 antagonist. So, sa heart lang gini sila, and you can give them to patients with asthma. Kasi, beta-1 receptor lang man, though na yung mga cases na bronchospasm, pero more on the higher dose na. So, we have the mnemonics na ginagamit, the BIM. BIM is betaxolol, bisoprolol, esmolol, atenolol, acebutolol, metoprolol, and nebivolol. So basig malibog mo ha, timolol, nadolol, propranolol ang non-selective, pero betaxolol and carcholol can be given to glaucoma. Okay? So si betaxolol is a beta-1 antagonist, and then we have bisoprolol, esmolol. This is a board exam question. Esmolol among the beta blockers has the smallest half-life. So it can stay in the body for, half-life ani kay 10 minutes. 10 minutes. That is why we give the esmolol as IV infusion So tuloy-tuloy na dose, especially sa mga hospitalized patient na kay IV man. And then atenolol, acebutolol, metoprolol, and the nebivolol. So among them, ang pinaka-ginagamit commonly is the metoprolol. So muna siya ang tambal sa silingan. Kanang makaingon yun, kanang hypertensive ka or high blood in layman's term, no? High blood ka, o kung ginainom metoprolol, muna siya ang kanang ginareseta sa silingan, which is supposedly dapat dili, ha? Kanya-kanya ta og kondisyon, kanya-kanya og tambal. Next, antagonist with partial agonist activity. So, antagonist sila supposedly, kaya lang naa sila partial agonist sa beta receptor. So, partial na lang, partial agonist sila. So, we have two, acebutolol and pindolol. Effective gihapon sila in treating hypertension with moderate bradycardia, hinay nga heart rate. Kasi antagonist ng gihapon sila. But they should not be given to patients with angina and arrhythmia because they are partial agonist. They can stimulate also the heart at certain doses. So, dili pud pwede for angina and arrhythmia. The rest pwede. And then, antagonist of both alpha and beta receptor. So, mabala ninyo sila class na dili lang sila purely for beta receptor. Mixed acting sila, pwede sila sa alpha receptor. Kasi ang ilahang pangalan do not end with olol. So, just like the labetalol and the carvedilol. So, I believe you are familiar with the carvedilol. We have carvid in the market. Ano na siya? Mixed acting. So, it can block the alpha receptors at the same time, the beta receptor. So, our alternative to methyl-dopa for hypertensive pregnant women ang labetalol. If dili available si methyl-dopa. And then, for heart failure, dyan ang atong ginagamit is si carvedilol. Okay, so that ends our discussion for chapter 7. Questions, class? We don't have beta-2 receptor blocker, ha, na kanang specific for beta-2 receptor, Jud. Kasi remember, if you block the beta-2 receptor, it can cause bronchoconstriction. So, kinsa may dili gusto makaginhawa dire. So, natural gina siya nga wala tay beta-2 selective blockers, ha? Kaya basig mangutana mo, asa na ang beta-2 blockers, ma'am? Siyempre wala. Kaya gusto ta makaginhawa. Nakuha to class? Questions?
Yes, ma'am.
Anything that you want to clarify? Wala na. So, assignment. Dili ni mo akong i-assignment, ha? Kasi wala mo'y libro. Kawa man tayo libro, I'll be giving you the assignment sa Schoology. So please open your account sa Schoology. Ito siya sa midterm na folder. You can see there. Wait. Let me publish it first kasi hindi ko pa siya na-publish. Actually, ano na siya? Case study. So, parehas lang sa mga ginahatag sa inyo, ha? You answered this. Publish. Ayan. So, tama-tama. It's almost 3 o'clock. Okay, so your assignment is already published sa Schoology class. You answer the case study. This is connected to our lesson this afternoon. This one. So sa discussion lang ha, diretso na sa discussion. So please understand the case and answer the questions. So we have here a 46-year-old woman sees her physician because of palpitations and headaches. She enjoyed good health until 1 year ago when spells of cardiac palpitations began. This became more severe and were eventually accompanied by throbbing headaches and drenching sweats. So physical examination reveals a blood pressure of 150 over 90 millimeters of mercury and heart rate of 88 beats per minute. So during the physical examination, palpation of the abdomen elicits a sudden and typical episode with a rise in blood pressure to 210 over 120 millimeters of mercury, heart rate to 122 beats per minute, and facial pallor. So this is accompanied by severe headache and profuse sweating. So what is likely the cause of her episodes and what caused the blood pressure and heart rate to rise so high during the examination? So what treatments might help this patient? So you can read books about this, mga adrenergic antagonist natin, and then their effects, understand the case, the condition of the patient, and answer the following questions. Okay, clarifications, class?